Dr. Rena Buckstein from Toronto will talk about hemoglobin transfusions and quality of life.
Thank you, Moshe, and thanks to the organizing committee for having me here today. Today, I want to describe the prevalence of anemia and transfusion dependence in MDS, in part how anemia and being TD impact quality of life and cardiac disease for survival, and then review the evidence in support of higher hemoglobin thresholds for our transfusions. These are my disclosures. Oops. So my first polling question is, which of the following statements is true? After a red cell transfusion in MDS patients, 20% endorse a reduction in fatigue, 40% endorse a reduction, or 65% endorse a reduction in fatigue. Please vote. Okay, thank you. Next question. And this is just my own interest polling question. On average, the hemoglobin threshold in which I transfuse MDS patients is, just read the answers on the slide and select which one applies to you. E is, I don't use a set threshold. It's personalized in every case. The results. Okay, maybe at the end. Okay, so I think we've known for a decade, more than a decade, that anemia is one of the most prevalent cytopenias in MDS, and moderately severe anemia is seen in 44% at the time of diagnosis and in even low-risk MDS. And we know that non-leukemic death, which comprises 54% of the causes of death, increases as a continuum as anemia deepens in both men and women, with the highest reduction or increase in non-leukemic death when your hemoglobin is less than 8 in women and 9 in men. And importantly, cardiac disease and death are strongly associated with severe anemia. And 63% of non-leukemic death is due to cardiac failure. And this is an observation in many other registries and studies that cardiac disease is probably the #3 cause that our patients die prematurely. So in addition to the known association between clonal hematopoiesis and inflammation and accelerated atherogenesis, what are other plausible reasons why someone who's TD or anemic has more cardiac events? So one could be the iron overload that's engendered. Certainly the reduction and the improvement in event-free survival seen in the Telesto study with iron chelation therapy would support that notion. And we did an analysis in the MDS registry in Canada at the impact of iron saturation versus ferritin as a metric of iron overload. And we found it to be what we feel a superior metric of true iron overload. And when we looked at the cardiac death-free survival in our patients, those who had a saturation of greater than 80% had worse survival. Another potential explanation would be the increased cardiac remodeling caused by severe anemia that with decreased preload, increased afterload, that leads to left ventricular hypertrophy and dilatation and ultimately congestive heart failure. And Dr. Oliva showed in her study that cardiac remodeling is found in 92% of patients that are TD versus 50% of those that are TI, with this kind of threshold effect with the hemoglobin of greater than 107. And in an ESA intervention study to improve hemoglobin, she showed that the cardiac geometry improved when the anemia was mitigated. So how common is transfusion dependence? So this large cross-sectional survey of hematologists in the United States showed that It's less common at diagnosis in lower risk patients, 22%, but it increases dramatically in higher risk patients. And these numbers are very aligned with what's reported from other large MDS registries, from Pavia and Düsseldorf and the EU MDS. And the EU MDS also showed us that even though the rates are lower at diagnosis, by year one, 41% of low-risk patients will be transfusion dependent. So this meta-analysis also highlights the importance of trying to remain transfusion independent. This is a summary of many studies, interventional and observational studies, that shows that the hazard ratio for death is much reduced if you remain transfusion independent. The risk of non-leukemic death is 80% lower, and your risk of AML is 25% lower. And timing doesn't matter. If you develop transfusion dependency at 6 months or 12 months or 24 months, each time in this sort of landmark study done by the Australians and Germans, it's clear that being transfusion dependent is associated with a 50% to 65% reduction in your survival. I would say that even in a low-risk MDS patient, being transfusion dependent effectively upstages you. Not to the degree of let's say, a TP53 mutation, but analogous to the idea that some of these somatic mutations upstage lower-risk disease. And Dr. DeWitt's already talked about transfusion density with regards to its impact on progression-free survival. In the Canadian MDS registry also showed that it impacted overall survival, but mainly seen in the lower-risk patients. The ELN MDS or EU MDS registry has shown, of course, and I think you all know these data, that the quality of life in MDS patients compared to age-matched controls is far inferior. And what predicts these scores are, on multivariate analysis, the transfusion dependence that is independent of anemia less than 10. So both are important, in addition to comorbidity and female sex and extreme age. And in this bar graph, I highlight the percentage of patients who are transfusion dependent in orange who have moderate to severe impairment in their EQ5D scores for mobility, self-care, usual activities, and their health utility or their visual analog score ratings of their health is inferior. And so I think as hematologists that transfuse MDS patients, we all know this data. So we know it's bad to be transfusion dependent, but is the achievement of transfusion independence a good thing? Does it impact on survival if you can convert someone from being TD to TI? And Dr. Santini will be presenting later at this meeting an analysis from the Medalist study. In responding patients, the survival is better. So starting TD and becoming TI is associated with improved survival. And similarly, she has recently published an analysis from the MDS 003 to 005 studies showing, again, that if you can become transfusion independent, even though you started dependent, you can have an improvement in your survival. What about quality of life? If you're starting off anemic and you improve someone's hemoglobin, do you improve their quality of life? And this very comprehensive review reviews the data, both from observational and interventional studies, about the relationship between hemoglobin, transfusion dependence, and quality of life. And the overall message is that in 8 out of the 10 ESA studies where it was measured, in 4 out of the 4 lenalidomide studies where it was measured, in 4 of the 6 HMA studies, an improvement, a response, improvement in hemoglobin, transfusion independence leads to or is associated with improvements in quality of life. But not all studies. 2 ESA RCTs did not show it, and the luspatercept study, the Medalist study, did not show it. And so we need to better understand what the limitations were, whether or not it really doesn't improve, or whether or not the way we measured it didn't reflect improvements. So to summarize my talk so far, TD and anemia associate with inferior clinical outcomes, dose density matters, it upstages lower risk disease, the achievement of transfusion independence associates with improved survival, and in most intervention studies, getting your hemoglobin up, getting off transfusions leads to improvement in quality of life. But we know the reality is metronomic transfusions are the way of life for many of our MDS patients, despite our best efforts, despite all the research going on. Our agents, we have limited number, limited repertoire, and they don't last forever. They're short-lived responses, even if we see responses. And so if you have a patient that's going to remain transfusion dependent, can we in some way improve their quality of life? For example, could we be under-transfusing our patients, maintaining them in hemoglobins that allow them to live, their vital organs to work, but not at levels that are congruent with normal functioning that they seek, day-to-day functioning that they seek? Could we be improving their quality of life, even though they're on transfusions, with higher hemoglobins? So in order to ask that question, we need to know at what hemoglobin are our patients being transfused, what are the thresholds they want, and is there evidence that higher hemoglobin thresholds for transfusion translate into benefit? So in this survey of 110 hematologists from Australia, 92% of respondents do set a transfusion threshold, 72% are customized according to cardiac history and symptoms, but the most common hemoglobin was 80, showing a restrictive approach with a post-transfusion hemoglobin target of 90 to 100. We wanted to understand the MDS experience from the patient perspective, and so we conducted this audit of 475 patients in the United States, Canada, and the UK. And the average hemoglobin at which patients reported, first of all, 80% of patients knew that what their hemoglobin threshold was, even though the majority didn't know what their risk score was, so that was interesting. But the average hemoglobin was 80, but we saw differences between the countries. The United States tended to be a little bit more conservative than the UK and Canada, and 47% of patients from the US were being transfused at hemoglobins of less than 75. And overall, 23% were being transfused at hemoglobins of less than 70. Our patients endorsed fatigue, 90%, weakness, 69%, dyspnea, 71%, and the symptoms that had the greatest impact on their quality of life that they reported were fatigue and dyspnea. So these are some targets that we should be trying to mitigate. The other interesting observation is patients, although the majority did feel better after they had a transfusion, many didn't feel better immediately. It took several days in about 55% and up to 5 days in 8% of patients. 26% endorsed a desire to be transfused at a higher hemoglobin threshold than their hematologist was currently adopting. And 62% wanted to be transfused to a hemoglobin of greater than 85, and 20% at a hemoglobin threshold of 100. And so this is something we should think about in our clinics. The reality is there is a paucity of data to inform optimal outpatient transfusion support in MDS patients. Dr. Abel from the Dana-Farber conducted a panel, and using a modified Delphi method established or set this sort of recommendation that if you have no end organ effects of anemia, like no cardiac dysfunction and so forth, patients can safely forego transfusions at a hemoglobin of 75 grams to a liter or higher. But we don't know how that impacts their quality of life. In the retro study, which was a study conducted in patients with hematologic cancers, 20% of whom had MDS, they found that definitely the impact of transfusions was beneficial. In about 50%, there was an improvement in 6-minute walk test, 51% improvement in fatigue, and a 42% improvement in dyspnea. But what you can see is that in this waterfall plot is that many patients don't have any improvement in their scores, and some even have decrements. So if we take the sort of belief that maybe a higher hemoglobin with better oxygen carrying capacity may improve the symptom and function of our patients with MDS, what are the trade-offs? And they're obvious, as listed on the slide. Is it worth it? And is it even feasible to achieve this? Can we maintain these differences? Can we reliably increase hemoglobin thresholds in our MDS patients and maintain these levels? So in order to ask this question, we conducted, in parallel with the UK group, UK, Australia, and New Zealand group, a 2 parallel, simultaneous, feasibility randomized controlled trials in patients who are transfusion dependent called REDS and RBC Enhance. And we randomized our patients between restrictive and liberal approaches to transfusion. And for the purposes of this analysis, I've combined our data, and we've submitted a manuscript about this to try to improve the power and the observations that we have. The RED study has already been published, and the ENHANCE study from Canada has not yet been published. The restrictive target maintenance hemoglobin was 85 to 100 grams per liter, and the liberal was 110 to 125 grams per liter. The primary outcomes were feasibility, and the secondary outcomes were, as listed on the slide, with assessment of quality of life as sort of an exploratory endpoint with a variety of quality of life instruments like the QLQC30 and EQ5D and FACT fatigue and so forth. The definition of compliance was keeping your hemoglobin greater than 20 in a difference of 20 pre-transfusion between restrictive and liberal in the RED study and 15 in the Canadian study. And they also had another definition that differed for us with regards to the pre-transfusion hemoglobin being below threshold 70% of the time, and we defined it as every 2 weeks, the hemoglobin being within the threshold that we wanted it to be. And so I can't compare those two because they're different. So what did we see? So patients in the liberal arm achieved a mean increase in their pre-transfusion hemoglobins of 12.9. We were able to maintain a difference, but didn't reach the 15 grams per liter for Canada or the 20 grams per liter of the UK when we combine our data. In order to achieve that, though, it was at a cost. Patients had to come for 5.6 extra CBCs over 12 weeks, 3.4 extra transfusion visits, 5.3 more units of blood, 5 fewer days between their transfusions, and their ferritin went up by 926. I don't have time to present the quality of life data, which is exploratory, and many of the curves are overlapping, but some of them do differ, and I want to just highlight a few things. So for the EQ5D, you can see the liberal arm reflected in the red curve is much stabler than the blue arm, which is the restrictive arm, which fluctuates. And that's interesting because the mean amplitude variation in the hemoglobin was 42% higher in the restrictive arm. Similarly, in the Canadian study, we asked our patients on a daily basis to rate their fatigue from 0 to 10. And over the 12-week period. It's called the ESAS Global Fatigue Scale. And what you can appreciate, I think, is that the red, which is the liberal arm, drops on the study. It fluctuates just like it does in the restrictive arm, but remains consistently below the restrictive arm, suggesting that maybe global fatigue is reduced with higher hemoglobin threshold. More patients in the liberal arm experienced minimally clinical improvement on the EQ5D, that sort of threshold 10 points in physical, social functioning, fatigue, dyspnea, insomnia, but not in all domains. And in the waterfall plot, you can see that the physical functioning score, the overall flavor is it does get better, there's more red to the right than there is to the left, which would show a decrement in physical functioning. But those dotted lines represent the MCID, the 10 points above and below. And many of these patients are staying the same. And as you can see in both arms, some are having decrements in their physical functioning. So it's not only about the hemoglobin to determine what our quality of life is going to be or what our physical function is going to be. So other findings, no major safety signals. The AUC, the area under the curve of many of our graphs was, of the quality of life scores, tended to be higher in the liberal arm for EQ5D, physical role, emotional, cognitive, and social functioning, and global quality of life, but not for dyspnea, for example. And accrual was slow. We only had a 21 to 31% eligibility. Fortunately, compliance with quality of life was very high. And so, the lessons that we learned were it's hard to maintain it's hard to be completely compliant with this difference of 15 grams per liter or 20 grams per liter. It does require more blood to keep somebody higher, and it raises the question of whether or not the sort of oxidative changes of stored blood or the coin lesion of stored blood is leading to shortened red cell survival. You may have to increase your inoculation if you're going to try to target higher hemoglobins and with more blood. It isn't feasible to embed quality of life studies. And though we did see the trend was some better improvements in many of our quality of life symptom and function domains, it wasn't in all of them. And it begs the question, are we using the right instruments? Are we defining what the correct MCID should be? Should we be looking at other metrics of benefit? And of course, this is experimental. If we're going to adopt this, we need some pharmacoeconomic modeling. So I want to thank you for your attention, all my co-investigators on these studies, and I think we'll finish off with the final questions. Oops. Which of the following statements is true after a red cell transfusion in MDS patients? 20%, 40%, or 65% endorse a reduction in fatigue? I think that the studies would say 40%. Next slide. On average, the hemoglobin threshold in which I plan to transfuse my MDS patients now is A85, B80, C75, D70, or I won't use a set threshold. It's going to be personalized in every case.